Okay.
This session is being recorded. Thank you all for joining us in the Sickle Cell Community Consortium and Red Hot Presents Warrior University online series. This series is all about blood transfusion, and you are calling in for Class 2. If you have a question that you'd like to ask, we ask that you please address those publicly, or you may send any private questions directly to Ashley Singleton. You can do this by clicking in the chat box. If you do not see a chat box on your screen, you may access it by hovering over anyone else's name and clicking the chat box that appears. Or on the bottom of your screen, there should be a series of icons. One of them is a chat bubble. You can select that as well. We do ask for those that are calling in right now, please go ahead and self-mute your line to cut down on background noise. You will be muted on this end as well, but you will be unmuted when it's time to ask questions. Again, type into the chat. Carolyn Booth is saying she does not have audio. Does everyone else have audio? Ekman, Ashley, someone confirm that you guys have audio.
Yes, we do.
Okay.
I have audio.
Okay, so that's an issue, individual issue. Amelia says, yes, I have audio, and so does Monica. Okay, fantastic. So we're going to get started. It is my pleasure to introduce Ashley Singleton, who will be moderating the remainder of this series, and we're turning it over to you. Ashley?
Okay, thank you, Lakia. Appreciate that. Thank you, everyone, so much for joining with us this evening. I know that you all have had a long day. I'm getting a little background noise. Lakia, is everything okay? Can you hear me okay?
I had a little bit of feedback, and you broke up momentarily.
Okay.
You sound much better now.
Does that sound better? Okay. Okay, so again, thank you all for joining this evening. I know you all have had a long day, and we really do appreciate you being here with us for the next hour. And you all have probably seen a lot of our logo floating around on the registration and on different websites. And so just to tell you a little bit about who we are, I work here at Georgia State University at the Georgia Health Policy Center, and we work on a project that focuses on reducing complications from blood transfusions for sickle cell and thalassemia patients. And so we work really closely with Dr. Ekman and a team of other medical professionals and also community advocates and people like yourself who give us really great feedback on what we can do to support the community. And so today, we want to have a conversation about keeping it safe blood matching. And in this session today, Dr. Ekman will cover a number of topics around blood transfusions, blood matching, cross-type matching, and we'll cover quite a few key terminologies and words that we want to encourage you to remember, maybe jot down in your notes. So we'll get to that in a second, but before we start, I wanted to ask you all a question. And so this is a polling question that will show up on your screen in a second. And for our folks on the phone, you won't be able to see this question, but definitely think about your response and what it would be. So I'm opening the poll now. We'll give you a minute to respond to this question. And the question is, should a person get a blood transfusion every time they have a pain crisis? And that's a yes or no question. So if you would, please respond to that. Okay, we have most of our answers in, and most people have responded with no. So this is something that we covered in our last session, and Dr. Ekman will review it again to make sure everyone understands why a person shouldn't have a blood transfusion with every pain crisis. We'll also talk about certain transfusion reactions and those important terms that I talked about earlier. It has a little maroon star next to those words. So pay close attention to the words that have the star next to it. So now I'm going to pass it over to Dr. Ekman to get us started. And while Dr. Ekman is pulling up the presentation, a friendly reminder to everyone, we definitely want to answer any questions that you may have, but please remember, if you need medical advice that's related to your specific medical history, it's always important to take those questions to your doctor or your specialist that you see.
Are we all set? Can you hear me?
Yes.
Okay, I didn't know if my audio was on. So I also want to welcome you this evening and thank you for joining us. Tonight what we're going to do is we're going to try and make you experts on what a transfusion is and what has to be done to prepare for a transfusion. And I want to do this because as we go through this tonight, I want to try to convince you that you need to know more about transfusions than your doctor does to really take care of yourself, because some of the things that are very important only you know, and I want to have you understand very basically what is involved in safely getting a transfusion, and then talk a little bit about some of the limitations. I'm going to review a little bit. I'm going to talk about things that we talked in the last session, and really, why do we transfuse? We transfuse because we can give red cells that contain more hemoglobin, and that puts more hemoglobin in the bloodstream, and it allows you to get more oxygen to your organs. And that's a benefit of transfusion that everybody gets when they're transfused. There's a second thing that happens in sickle cell that's even more important, and that is the sickle cells are diluted out by the normal blood cells, and that tends to break up the traffic jams that occur when the sickle cells sickle in the bloodstream. And so in addition to just increasing the hemoglobin level, diluting out the sickle cells will make the blood flow better, which makes clinical situations better even faster. Now, we're stressing transfusions because they still are the single most effective treatment for sickle cell disease. And for many serious complications, they're life-saving. They're really, really important. Regular transfusions can also be used as prevention, and if you get regular transfusions for strokes, acute chest, recurrent pain episodes, or other complications, the transfusions can actually prevent them from recurring. And finally, when you get a higher hemoglobin level, you get more oxygen to your tissues, your heart doesn't have to work as hard, and you're going to feel better. You won't be as weak, you won't be as short of breath, and you'll have more energy. And so, there's a lot of benefits to transfusions, and then the question has to be answered, well, if transfusions are so good, why don't we transfuse everybody all of the time? And this slide sort of summarizes why that occurs. And on the left is the yin and the yang, which is our positive forces and negative forces. And everything we do in medicine has a positive effect, but it also has a negative effect. And so it's extremely important that whenever we're doing any sorts of treatment in medicine, that we balance the good effect against the bad effect and make sure that those are equal. And so to understand why we don't transfuse all of the time, we have to understand what are some of the downsides of getting a blood transfusion. Are there any questions to this point, or can I go on?
There are no questions in the chat box.
Okay, so I'm going to move ahead. So what are the downsides? Well, when you're get transfusions, you can have problems. You can have transfusion reactions, and we'll talk about those in detail. you can develop antibodies to the transfused cells, so it becomes very hard to find blood that matches you. You can have iron overload, where you just get too much iron in your body, and we're not going to talk about that tonight, but in the next session we're going to talk about that in detail. And then finally, one of the most important things people are concerned about is infections, and there is a small risk of getting infections from a blood transfusion, but there are many, many things done now to minimize that risk. But all four of these can occur, and they're the downside of getting a blood transfusion, and really why we can't do it all the time for everybody. Well, what is a transfusion reaction? Well, there's really three basic types of transfusion reactions. One is an allergic reaction, and these are usually very mild, although they can be severe. Very often what somebody will notice when they're getting a blood transfusion is they'll develop a rash or itching. They may have wheezing, anxiety, and low blood pressure, and that's one of the more severe complications that can occur. One of the more common ones is to have fever, and very often individuals develop fever during a transfusion. And actually, most often this fever isn't related to anything serious, but it has to be taken into consideration. And then finally, you can have what's called a hemolytic transfusion reaction, and this is really the important thing that we want to talk about tonight. Because a hemolytic transfusion reaction results in the breakdown of the transfused cells very rapidly, and it can cause all sorts of other problems. So if a transfusion reaction occurs during a transfusion, the doctor or nurse will immediately stop giving you the blood for any of these reactions. After that is done, then they'll do some clinical things and laboratory things to see if this is a serious problem like a hemolytic transfusion reaction, or one of these milder problems which can be actually managed by giving antihistamines to stop the itching, or acetaminophen or aspirin to stop the fever, and then it's safe to go on with the transfusion. But if there's a hemolytic transfusion reaction, then the transfusion has to be stopped completely, and a complete evaluation has to be done before it's safe to give you any more blood. So there are good and bad, or yin and yang, for each blood transfusion, and there are a bunch of different types of transfusion reactions. Are there any questions at this point?
Yes.
Okay.
So this question says, I've had only a few transfusions and I developed antibodies. So having lots of transfusion was not my case. Are there any other reasons for developing antibodies?
That's a great question, and the answer is that we don't understand why yet, but if people get transfused, as a broad generalization, the more blood you get, the more likely you are to develop antibodies to that blood. There are about 30% of the population that seem to be very sensitive to developing these antibodies, and we don't know why. And I have had patients that develop 4 or 5 antibodies with just one transfusion. More commonly, 70% of the time, nothing happens. And if you get a lot of transfusions, like about 100 units over your lifetime, there's about a 50-50 chance that you'll develop antibodies. And so there's a predisposition to getting antibodies that we don't understand, and we're working on that to try and figure that out. It does have something to do with the regulation of the immune system in those individuals, but we don't know exactly what that is yet. And the other answer is that as far as we know at this time, that doesn't predispose you to having any other types of problems. And part of the research that's being done around blood transfusions is to try to figure out why that occurs, and so we can identify individuals who are likely to to develop antibodies before we ever give them their first transfusion. That's a long answer, but it's a very complicated and excellent question. And the honest, simple answer is that we really haven't figured that out yet.
Okay. Dr. Eggman, we have one more question.
Okay.
Second. This person wants to know if a patient is currently having a fever greater than 100.4, is it safe to initiate the transfusion? Uh-oh.
Yeah, I had a problem here. Just a second. Okay.
Okay. I'll give you a second there.
So I'm sorry, can you repeat the question?
Sure. This person would like to know if a patient is currently having a fever greater than 100.4, is it safe to initiate the transfusion?
That is a complicated question that I can't answer. The only thing that I could say is maybe, and that would really depend on what the cause of the fever was. So if somebody had an infection and was already getting antibiotics for that infection, and they needed a transfusion, then it would be safe to give the transfusion. Normally, we don't like to transfuse when somebody has a fever because we can't tell if they're having one of the more serious types of transfusion reactions. So the answer is that it may be. If you can identify why there's a fever and start treating that, or like an infection with antibiotics, then it's probably safe to give the transfusion. But until you can figure that out, it's often delayed until they know why the fever is there.
Okay, that was the last question.
Okay. Now we're going to go on to something a little more complicated. Does everybody know what an antibody and an antigen is? Does anybody know? So hemolytic transfusion reactions, which I said were the most serious ones, are related to developing an antibody in the plasma that interacts with an antigen that's on the red cell. Well, what is an antibody and what is an antigen? Well, it's kind of like a lock and a key. The antigen is like the lock, and inside the lock there are little tumblers, and if a key is present that exactly matches those tumblers, then the key will open the lock and you can get in through the door. An antigen is very much like the lock, and the antibody is like the key. And if the antibody exactly matches the antigen on the red blood cell, then the antibody binds to it and it opens up the red cell, and that's a transfusion reaction. Because the hemoglobin leaks out and the red cell is broken, and both are lost from the circulation. An antigen is a protein or sugar on the surface of the red cell, and it has to exactly match the antibody for something to happen. There are about 600 different antigens on the red cell that could interact with antibodies, but only a few of them do. So an antibody is a protein that interacts with an antigen, and when the antigen is the lock on the surface of the red cell, that binding causes the red cell to open up and the hemoglobin to leak out, and that's what hemolysis is. So is that clear to everybody? Antibody targets bad things. The reason we normally have them is things like germs and cancer cells and parasites and other things can get into the blood. And these antibodies are really good things in that situation because they bind to antigens on those germs or cancer cells, and they open them up and destroy them. And so that's why we have antibodies. But with transfusions, they can cause problems that we have to deal with. Any questions, Ashley, or should I move on?
You can move on.
Okay. So let's talk about blood types. Everybody, I think, knows that there are blood groups, and your A, B, O, or AB. These major blood groups are important because all of us have antibodies to antigens on the red cell if those antigens aren't on our red cell. So if an antigen isn't on your red cell, there's A and B antibodies that form in the plasma. And the reason these are so important, if you mismatch these, if these don't match up perfectly, the antibodies and the antigens, then you have a major transfusion reaction and get real sick. Now, this sort of shows what the blood types really stand for. If you have a no antigen for A or B on your red cell, you're type O. So you don't have any antigens that are going to cause a problem, a major transfusion reaction when you're given red cells. If you're type A, you have A antigen on your red cell. If you're type B, you have B antigen on your red cell. And if you have both A and B antigens on your red cell, you're type AB. Early in life, individuals who have type O make antibodies for both A and B. Individuals who are type A make B antibodies. Individuals who are type B make A antibodies, and individuals who are type AB don't have antibodies in their plasma to either A or B. What this means is a donor who is O can give blood to anybody because they don't have those antigens on their red cell, and individuals who are AB can get blood from these other groups because they can't make antibodies to them. And so these are the major blood groups, the AB, and those are the four basic types that everybody knows about. Now, it's actually much more complicated than this. Does everybody understand what I've talked about to this point in terms of the major blood groups? Are there any questions?
There's one question, Jim. This person says, I'm O positive, and have antibodies. I needed a blood transfusion. For 3 days, they couldn't match my blood. So I asked, could they transfuse me with just O positive, and they did. My recovery time was longer. Was the blood used the reason? Was the blood?
We're actually going to talk about that, and the answer is that probably not, because they did much more than just give you type O blood, and I'll explain that as we go forward. We'll come back to that, and if it's still not clear at the end, we'll please ask the question again. Okay?
Okay, that's all, Jim.
Okay, we're going to move on then. So what we're going to talk about now is typing and cross-matching, and I alluded to this a little bit in the first talk, but how do you type the blood? Well, you use a reagent that's serum, and you have two different vials. One has serum in it that has an antibody against A, and the other has an antibody against B. And you take the person's blood and you mix it with that serum. And you mix it with both the A and the B separately. And if there's clumping, the red cells all clump together, that's called agglutination, and that's a positive reaction. And that means that the antigen is on the red cell that the serum reacts to. So if you're using anti-A and there's agglutination, then you have A antigen on your red cell. This individual reacted to anti-A but not to anti-B, and so this individual is type A. And so this is how you type the blood. And so when you have a type and cross match ordered, the first part of this is to do a type, which is to look to determine whether you have A or B, both or neither, and then you get the 4 basic blood groups. Now the second thing that's done is called a cross match, and in the cross match they take the donor's red cells and they react it with your plasma. And the reason they do that is if there's any antibodies to anything on the red cell, then those cells will clump, and that's a positive cross match, and they have to figure out why that occurred, and it's likely related to other antibodies other than just the A and the B. And we'll talk about those in a second. And so that's what's done in the laboratory to determine if the blood is safe for you. The other thing that's done that's equally as important is at the bedside, and the nurse will take the unit of blood and look at the label from the blood and very carefully match that to your wristband to make sure that there's an exact match and that you're getting the right unit of blood, because clerical problems can cause transfusion reactions even if the work that was done in the laboratory is perfectly okay. And so that's how you type and cross the blood, and what's done every time you need a transfusion. Now, the reason that sickle cell patients have trouble with transfusions and get antibodies is actually a bit more complicated. And we talk about A, B, but there's really an alphabet soup of antigens that are present on the red cell. And remember, I said there's about 600 on the red cell altogether, and only about 24 of these turn out to be important. That is, that they're antigens that people can develop antibodies to that can cause transfusion problems. And there's big C, little c, D, which D refers to RH, which is what the positive and negative mean. So somebody who's A positive has a D on their red cell. An individual who's A negative doesn't have a large D. And there's large E, large, small e, there's K, small k, and there are many more antigens. When you're exposed to any of these antigens with a blood transfusion, then you can make antibodies to them. And so if you lack these on your red cell and you get red cells that have those antigens, then you can make an antibody to these. And this is what is called a minor transfusion reaction. So the cross match is done, and that's a final check before transfusion to make sure that it's safe to give that unit, and there are no antibodies in that unit that are going to interact with any antigens on your red cells. And this is something that's done in the laboratory. Are there any questions at this point?
So, Jim, there are no questions in the chat box, but I do want to plant a question. So how should a person find out if they have antibodies or not? Where do they get that information? Who should they ask or talk to?
Okay. Excellent question, and after a 30-second break, I'm going to answer it with the rest of the talk.
Okay, that's great.
You read my mind. You're a little bit ahead of me, Ashley, but that's good.
Okay, so everyone on the call, I know we covered quite a bit of information, so we just want to give everybody a quick few seconds to just process all that you've just heard. I had a cute little cat video, but we won't worry about pulling that up.
All right.
Okay, so we have one comment here. Let me just read it. Okay, so this comment, Jim, this comment says, due to shortages of specific blood types that are not always available in, I guess, a healthcare setting, we rely on compatibility charts. Is this discouraged with sickle cell disease?
Yes, it is. It really is, yes. We'll get into that a little bit, but yes, that's something that probably should not be done with the sickle cell individuals with sickle cell disease. And it sometimes has to be done because there's just no other alternative. You can't find blood that matches perfectly. But I'm going to explain why that's probably not a real good idea in sickle cell disease. Should I go on?
Yes.
Okay, well, why is this a problem? Well, minor blood groups are formed by exposure to previous red cells. So you don't make these on your own. You have to be exposed to other person's red cells. And there's two ways that it can occur. One is through transfusions. And whenever you get blood transfusion, then the possibility is that you're going to see an antigen that you can make an antibody to. The second one that most people don't think about is during pregnancy, because during pregnancy, the fetus, there's usually a little bit of bleeding between the fetus and the mother, so she gets some of the fetus's red cells into her bloodstream. And this is another way that she can be exposed to antigens that she can make an antibody to. Now, in sickle cell disease, before transfusion, the individual needs to be screened for antibodies to minor antigens in their plasma. And this is a little different than what I talked about before in terms of the ABO testing, but it's required to make sure antibodies aren't present, and this is particularly important in sickle cell disease. So they have to be screened. And if you have an antibody in your plasma, the transfused cells have to lack the antigens to which you have the antibody. So the screen is done to find antibodies that are to the minor blood groups, all of that alphabet soup I talked about. And when you have an antibody to the antigen, you can't get those kind of red cells. And D is important to everybody. That's the Rh factor, and that's why we always say A positive or B positive or O negative. And that talks about the major blood group, but also D, which is a very important minor blood group. In sickle cell disease, there's a whole host of other antigens that are important. C, E, Cal, and JKB are the most important, but there's another half dozen or so that are important, quite important. And this is unique to sickle cell disease and is a very important aspect that you have to understand, because this is the major reason that it's difficult to give transfusions to sickle cell patients in many settings. And I have to talk about what happens when you get a transfusion with a minor antigen that you have an antibody to. Well, first of all, you have to be sensitized. You have to get the first exposure. And when this first occurs, you make a little bit of antibody. And in this slide, we have time in weeks, and we have the amount of antibody formed, which is this red line. And so when you're first exposed to the antigen, you make a little bit of antibody. Some of the red cells are destroyed when the antibody binds, it punches a hole in them, and so you get a little bit of hemolysis. But usually that's not too much of a clinical problem. Now, if you don't get transfused again for a long period of time, weeks or months, then that antibody will disappear. It won't be testable in the laboratory. You won't be able to do a screen, do a screen and detect that antibody. And when you do the cross match, it will be perfectly normal, so that you'll think the blood is safe to give. But once you see that antigen again with a new red cell transfusion, then you make lots of antibody. And this causes destruction of almost all of the transfused cells. And this usually causes a really bad pain crisis. And it also causes you to destroy your sickle cells. So not only do you get rid of all of the transfused cells, but it actually destroys some of the sickle cells. So it makes your hemoglobin go down, not up. It's lower than before you got the transfusion. And so this is very important, because this is how we really have sickle cell patients get into trouble from transfusion. And about 6% of the time, this is such a severe reaction that it's actually fatal. So this is something that really is serious that has to be avoided. And the reason that I'm giving this talk about the antibodies and going over all this complicated things is because the only way we can know, the only way we can know about the fact that you've made an antibody is because we know you've had it before. And so that means we have to be able to take a history and find out that you've been exposed to blood before and that you've made an antibody. And we also need to know what that type of antibody is because we need to be able to match your blood for it even if the antibody isn't present, because we know if we don't, you'll have a really bad response. And so this is the main reason why it's so important that you keep careful track of where you get your blood transfusions and whether or not you've had any transfusions in the past that have caused problems, and also to have a history of whether you've got antibodies in your plasma already. So why is this so important in sickle cell disease? Well, because sickle cell patients get many transfusions over a lifetime. And as I said, some people will make antibodies with the first transfusion, but the more you get, the more likely you are to develop these kind of minor antibodies. The other thing that's very important is that individuals with sickle cell anemia lack many antigens that are present on the donor cells. Individuals of African heritage, where their relatives or they're descendants of individuals that grew up in Africa generations ago, lack many antigens on their red cells that are present on Northern European blood donors. And so there's constant exposure to these individuals with sickle cell disease from blood from European donors that have antigens that they don't have on their red cell. And so this predisposes them to having problems. The other thing that happens that's extremely important is that sickle cell patients get transfused in many different hospitals over their lifetime. And the only individuals who really know their history of transfusions are the patients themselves and their families. And so keeping good records, making sure that you make a doctor aware of where you've been transfused in the past and whether you have problems should be done every time before you get a transfusion. And so keeping a careful history of your transfusions and antibodies is very important. So what do you need to do to prevent these kind of transfusion reactions? Well, you need to track your transfusions and keep a record with you at all times that has your major blood type and also all known antibodies that you've made in the past to previous transfusions. And it's really good to have a medal alert on your wrist that at least has the fact that you have antibodies on it. And if you only get transfused mainly in one place, that the name of that hospital and telephone number is actually on your ID bracelet, because it allows the blood bank and where you're getting the transfusion to call places where you've had past transfusions and get the history that they need to safely give you blood. If you do have any kind of a transfusion reaction, you should really ask what type it is, when did it happen, and where did it happen. And it's very important to keep track of your last transfusion and know the name and phone number of the hospital where you were transfused. And you have to be very specific, because many hospitals have the same name around the country, and mistakes can be made because you think you're in Methodist Hospital in St. Louis and you were actually transfused in Methodist Hospital in Detroit. And so you have to be very specific about that history. And then if you do demonstrate that you're going to make antibodies to transfused cells, minor antibodies, the blood bank should go ahead and determine all of the important antigens on your red cells that you might make an antibody to. And with future transfusions, they will match you for that phenotype. So instead of giving you blood where you just don't have antibody in your plasma, they'll actually match your red cells perfectly with the transfused red cells, and that's called phenotypic matching, and that gives that gives much greater safety in terms of being able to tolerate the transfusion. And then once you've developed antibodies to the minor blood group antigens, it's really important to minimize the number of transfusions you have. That's really one of the more important ways of preventing problems in the future. So, in order to transfuse individuals with sickle cell appropriately, everyone with sickle cell disease should be transfused with D negative, C, E, and K similar units. So if you lack any of these antigens, you probably should get blood that lacks those antigens. Once you develop an antibody, then you must be matched for that antigen. And so if you don't get matched perfectly, you'll have a delayed transfusion reaction, and that can be serious. And in order to do this and make it work, all patients need to keep records of their transfusions, and it's extremely important that the clinician takes a detailed history before the transfusion, and if they don't, you should remind them that that's something they need to do. And then finally, in order to get appropriate blood for the sickle cell population, it is really important to recruit for blood donation from the family and from the African American population, because as I said, those individuals are more likely to lack the antigens you've been sensitized to, and they'll make a better donor than the usual donor that you'd get from the general population. Okay, so I'm going to stop there, and Ashley is going to give you the polling question. This is all I have to present formally, but I will certainly try and answer any questions and help you understand things that I may not have said clearly enough.
Okay, and Jim, while I'm loading the polling question, we did have a comment. It wasn't a question, and then we also have a question. So first, the comment. Asabi wanted to just share that she had an exchange transfusion during her pregnancy in 2000, and then 7 years later, her doctor in a different state asked, "Do you know you have antibodies?" And she didn't know what the doctor was talking about. And so she says that to this day, she doesn't know what antibodies she has. So she's just saying she's lucky that she hasn't had any mishaps. So.
Right. And actually, it's I think that's really true, but it's also more important than that. She should really go back and get the information from that hospital where they identified those antibodies, and that should become part of her permanent medical record, because if she did need a transfusion in the future, she should be matched for those antibodies, because otherwise she could have another transfusion reaction in the future. Is that clear? That's the kind of history you really need to have available whenever you get new transfusions, so that your blood can be matched, because even though it isn't present at the time that they do the test in the laboratory, you still will be able to have a reaction, because you'll rapidly make a new antibody, even if it was done many, many years ago. What was the second question?
The second question is the D antibody also known as RH factor?
Yes, D antibody is the RH factor. The D antigen is the RH antigen. Yes.
Alexis says, thank you for describing why it is better for people to get blood donation from people of the same descent. She was going to ask that question, but you answered it. And we are going to have a class that's going to talk a lot about minority blood donation and why it's so important to us. We're going to get more into detail of that in a later class, I believe. And Asabi commented she's on it. She'll be getting her records and taking care of this.
Excellent. Thank you. That makes me feel good.
Okay, great. So I'm going to open the poll, you all, for the first question. And again, for the folks on the phone, you probably, you can't see this, but the question is, I know my blood type. That's a yes or no question. And it's just 15 more seconds, so if you're on the phone, if you would, on the computer, if you would, please answer. So we have, most people do know their blood type. There are a few that don't. Dr. Ekman, for the people who don't know their blood type, can you again just tell us how they can, or where they should go to get that information?
They should be able to request that at their doctor's office. Knowing your ABO blood type isn't as important as knowing whether or not you have minor antibodies. So having antibodies other than ABO is more important than the major blood groups for you, because whenever you get a transfusion, they're going to determine your major blood group, and they're going to always honor that the best they can in terms of giving you a transfusion. So that one is not as important, actually, is knowing what the fact that you've had antibodies in the past to the minor blood group antigens. And that's because you have, for the general population, they only get transfused once or twice in their lifetime at most, so that only the major blood groups are really important to them. But when you get repeated transfusions, then the others are known. And one of the things that's been recommended in the NIH recommendations for sickle cell transfusions is that actually everybody should know their major and their minor antigen type, but not all hospitals are doing that yet. But you should be able to be tested for your ABO and RH blood type at a hospital. I don't believe it can be done at the American Red Cross, but I think your doctor's office or the hospital could do that.
Okay. And that's a great segue to the second question. So if you all would just pay attention to your screens, the question is, I know if I have any antibodies. So 30 seconds on the clock. If you would, please just respond. And again, your responses are anonymous and private. We don't share any responses with anyone else. So we don't have any responses to that question, so I don't know if our folks on the computer are still thinking about it, or they just aren't sure. But that poll question has ended. So, okay, we did have some responses. So we had about half and half, Dr. Ekman. Half of the people said yes, they know if they have an antibody, and the other half said no, they don't.
Okay, well that I would encourage everybody to find out, that you should talk to your primary care doctor for your sickle cell and make sure that you are aware of whether you have antibodies or not.
Okay, great. So I'm just checking the chat box again to make sure we've covered all the questions. Someone asked about notes on the session tonight. Lakia, correct me if I'm wrong, but these slides, the recordings, everything will be posted on the website, on your website?
Yes, that's correct. That's correct. After the classes end, the presentation as well as the recordings will be available online.
Okay, great. And then the last question here, this person wanted to know if they ask their family member to donate blood, even if they have traits, would they be able to donate?
Okay, that's a great question. So yes, individuals with sickle trait can donate. The only hesitation about using the sickle trait blood in sickle cell disease is that if sometimes the physician wants to monitor the amount of S hemoglobin and normal A hemoglobin after the transfusion. And if you have sickle trait, that will confuse the issue. But the sickle trait blood is fine for transfusion. There's no reason not to use it, other than it makes it hard to keep track of the exact percentage of normal cells and the exact percentage of sickle cells that are left after the transfusion. Is that clear? It's a little complicated, but and then the other thing is that it really is important, because that blood can also be used if you don't need it from your family member, that can be used for donation to other people. And there's always a chronic blood shortage, and so it's important that everybody is a blood donor, and really takes every opportunity they can to give blood.
And
especially
we will
for African American. And Ashley's going to talk to you about that, I think, into the 4th session, right?
Yes, on March the 6th, we'll talk all about African American blood donations and their importance. We'll also have someone on the call with us from Red Cross who will talk to you about how to host a blood drive if you're interested in learning more about organizing a blood drive. So I see Alexis just asked about that. We will have someone from Red Cross on March the 6th joining us to talk about that. Okay, I think that's all of the questions in the chat box. So, Lakia, I will pass it on to you to close us out.
Wonderful. Everyone, if you have any last questions, now is your time to ask them. Thank you very, very much, Ashley and Dr. Ekman, for the wonderful presentation. I did want to share with everyone that we do have, these classes are Mondays and Wednesdays, so our next class is not until next week. These first 2 sessions have been excellent, and so very glad you've been able to talk with us about this. On Monday, we are going to talk about another session on Keep It Safe, designated design for iron overload, and we'll get into the details of that and everything that you need to know. On March 6th, we're going to talk, as was mentioned, about African American donation, blood donation, why it's important. This is a good one for the CBOs to participate in, independent advocates who want to learn more about how to host blood drives. Come on board and learn more about that. And then March 11th, the Let's Talk patient-provider communication. This is the opportunity to talk about that communication, and it's an incredibly important topic as well. That will wrap up this series, and then on the next series in Warrior University coming up is on FDA and how our patients and caregivers can interact with the FDA to become part of that so that we can see sustainable change in the sickle cell community. And we also have a series of classes coming on the NHLBI guidelines for sickle cell treatment. Thank you all very, very much for joining us. We look forward to seeing you all back here on Monday. Oh, there's a last-minute question. Ashley?
Yes, and Dr. Ekman, Amelia had one last question. She asked, oftentimes during a transfusion, a patient develops a fever. At what threshold above baseline should the transfusion be discontinued?
Usually it's 1 degree or 2 degrees at the most that you allow. It has to be stopped and investigated, and then it might be restarted.
Okay. All right. Amelia said thank you. Everyone has said thank you, and we want to say thank to you for sending your questions and joining us tonight. There is a question about what literature a layperson can read. What we can do is we will try to pull together some resources and send out to the group if that's helpful. We can, Dr. Ackerman, maybe a few of us on the team can think of some places where we can send people who have questions after the series, like helpful resources.
Yes, I think there's some things that will go into it in more detail that we can reference, so people will have those available.
Great. Thank you all so much for joining us this evening.
Thank you.
Thank you, everyone.
Yep.
See you
Good
all on
night.
Monday. Bye.
Bye.